presented by Ms. Ann Moodie. Ms. Moodie is an outpatient therapist, and she has a concentration in marriage and family therapy. And she's also a master certified life coach. She's the owner of Foundations for Life, Youth, LIFE, in which she provides individuals and their families with counseling services and self-empowerment, coaching, workshops for teens and young adults. She received her graduate degree in clinical psychology with a concentration in marriage and family therapy. And with over 22 years of experience working with children and their families, she's going to certainly give us some very good information that we can march on with. She is first generation Jamaican American, and her parents hail from St. Catherine and Kingston. And with that, I would like to turn the mic over to you, Anne, for the presentation.
Hello, everyone. Nice presentation. Thank you, Carlene. Okay, so I titled this presentation Suicidality because it's a term that includes serious thoughts and plans as well as attempts. So I wanted it to be all inclusive and not just focus on thoughts alone. So let's see, I'm going to share my screen so I can do the presentation. I didn't record it, so I'll be reading notes that go along with what you see on the presentation. So let's see here. Oops.
Somebody said they're having audio issues. I'm hearing you clearly, so I think Ms. Shelley Ann Heron, it might be on your end.
Are you hearing me clearly?
Oh yeah, I'm hearing you very well.
Okay.
So hopefully Ms. Heron is able to address that.
Okay, let's see.
We'll get the share screen button there. That looks like something happened.
Okay.
Okay. There we are.
Let me make this bigger. Okay, suicidality, risk and prevention. I think it's very important for us to know the risks that we're faced with, and from what I've learned over the years, we tend to get afraid when we encounter individuals that have suicidal ideations, because we take on that whole responsibility, like we have to save their lives and it's our responsibility. Everything is on us, but we have to assist and help. So when we put that weight on us, it makes us fearful to work with individuals who are dealing with depression and having thoughts of ending their life. Let's see, my clicker. I don't have my clicker, I apologize. So briefly, we're gonna have an overview, understanding suicide, risk factors, interventions. I'm not sure if we have any other mental health professionals on with us, because if it's mainly teachers and guidance counselors, I won't spend too much time on interventions because, of course, you would have to refer to a mental health professional, but I just wanted to briefly go over that to include what those interventions look like so that you know what goes on with any student or any other person that may be facing suicidality. Also, assessing and estimating risks, family involvement, which is really important post-vention, because as we know, after the fact, there are persons that need guidance for weeks and months down the road after an attempt. So postvention is important. And also responsible communication tips. A lot of times we don't know what to say, or we say the wrong thing, or we say something that triggers. So it's important for us to learn some of the language and be responsible with the words we use and how we communicate with someone facing an attempt or going through depression. Okay. So suicidality, the term, as I mentioned, is inclusive of the ideations and the thoughts of taking one's life. It includes plans and also attempts.
And if
Yeah.
I could interrupt, somebody's asking if you could put it in presentation mode. I think because
Yes, because of the time.
yeah, this side we have our faces covering a lot of the language. Thank
Yes.
you to whoever made that suggestion.
Oh, let's see. Go. Oh. Uh-oh.
I think that should be good.
Think this is okay?
Yeah, it should be
It's
good.
okay, but it's not usually how I see presentation mode, but it works.
I'm using a different computer today.
Okay.
So what are you seeing, Carlene?
We're seeing, and now it's better because you could actually see the presentation and it's not encumbered.
Okay, so what she could do is just go back into slideshow, and then she could read from her notes. Okay, okay, Anne?
Go back into slideshow?
Yes, just go back into slideshow. Don't do presentation mode. Don't do presentation mode, because that will have your notes and stuff in there.
Okay, hold on.
Mm-hmm.
Okay, what happened is I have two monitors and it opened on the second screen. So that's what happened here. Okay, so
So go up and go to slideshow.
Slide, oh, the top.
Up to the top, across from home, all the way across to slideshow.
Right,
There you go.
See, now it was showing this way.
Okay.
Second screen.
Oh.
No, it's showing how it's supposed to show on my second screen, but my second screen doesn't have a camera.
Ah.
Okay.
We don't have too much money to. When you have too much, this is what happens. If you only had the one, we'd be okay.
Yes.
All right, so we'll.
So let me go back. I think it's better if I do this way, and then I'll be reading from the notes so that if you can't see all of the wording, and I won't read too fast if you need to take notes about anything.
And I will note to folks that this presentation is going to be available afterwards, right, Kimon? We'll be able to.
I'm on mute talking. Yes, we'll definitely post this one since it's not showing up properly. Absolutely.
Okay. So the language, I want to explain a little bit about the suicide language. Suicide thoughts or ideas or ideations are ideas about ending life. And a suicide plan marks the next level of seriousness. It occurs when someone is so frustrated that they come up with a plan for how to end their life. An attempt, suicide attempts are the hardest to define, but someone does something to intentionally end their life, they have made a suicide attempt. So as you can see, I have it suicide thoughts, plan, and attempts. The thoughts are the low risk, the plan are the next level of risk, and the suicide attempt is the high risk. Here are some of the risk factors associated with suicidality. These mental health disorders are what you would commonly see with someone contemplating suicide. I'm not sure if you would like me to explain a little bit about the disorders, because some people don't know what to look for unless you're a mental health professional. But I have some brief overviews of each diagnosis, and I can explain that to you.
That would be good.
Okay. So for bipolar disorder, in a manic episode, I don't know if you've heard more of the manic phase, the hypomanic, or the depression mode. Manic episode is a greatly elevated, persistent, heightened mood, increased activity and energy and irritability, and it lasts about a week. So if you notice that with any students, you can observe these things and engage with the person if you suspect that something else is going on. A depression and hypomanic mode is about 4 days. The same thing as a manic episode with persistent heightened mood, increased activity, irritability, but it's shorter. So it only lasts about a few days. And then depression also is a persistent negative mood, diminished satisfaction or pleasure in nearly all activities. Weight loss, for some people it is weight gain, sleep problems, tired, feelings of worthlessness, difficulty concentrating, and it typically lasts about 2 weeks. So I don't expect you to be an expert on mood disorders, but those are certain signs, especially if you know a student very well and you see that they're not acting themselves. These are certain things you can look for. Depression is the same negative mood lasting for about 2 weeks. Behavioral changes that go along with drug and alcohol dependence. Schizophrenia is not as common with teenagers, but it can happen. They typically have hallucinations, delusions, disorganized, incoherent speech. They are lacking academically, their interpersonal relationships are suffering, and a lack of self-care. So if you notice that someone is unkempt and not taking care of themselves and they have all of these other symptoms with the hallucination and delusions, that's something else to take note of. PTSD. PTSD is something that I find very common with young people that are contemplating suicide. They don't have to be directly impacted by the trauma. There are many young people that go through what we call secondary trauma or vicarious trauma. But typically people with PTSD have experienced an actual or threatened death, serious injury, sexual violence. They could witness a trauma. It could be a close friend or a family member. They typically have recurring memories, nightmares, flashbacks about the event, dissociative reactions, and that's like feeling like they're reliving the event all over again. They can actually watch themselves go through the event again also. Intense reactive distress. So for instance, you're in school with a child and someone drops their textbook on the tiles on the ground, and it makes a loud slap, and the student jumps, and it's really exaggerated. They jump out of fear. And if it's out of the normal startle response, that's a clue that maybe something is going on. They typically also try to avoid symptoms and have a negative mood. And then there's also anxiety disorder. This typically is about 6 months, and it's excessive worry. The person finds it difficult to be agitated, loss of energy, difficulty focusing. If you notice, they're having problems in class, focusing on their work, they're irritable, and they have difficulty sleeping. And then the last one is stressful life issues. So it changes with age. So for some families, you have some families that are really careful about not letting their children know about the financial issues that are going on, so they may not be aware. So sometimes it typically lays on an adult, but in many cases, the child is aware and may feel like, because they overheard conversations of mom or dad losing a job and losing their home, they may feel like, if I were to go away, maybe things would be easier. So sometimes even children are dealing with the serious financial issues of their families. Relationship problems. Teenagers, typically, they get into relationships and they take it very seriously. It means everything to them because it's new for them. Excessive bullying, this is important because some children go through bullying, but typically bullying with humiliation. That seems to be the deal breaker to, encourage a child to want to look at suicide. So in this day and age, we have cameras, phones, and social media, it's have even been heightened even more, because now you have the sexting issue. Teenagers are sending pictures of themselves to other people, and they trust them, but sometimes it gets out. Everyone knows about it, it's circulating, and they may feel like, because of that humiliation, that they don't want to live anymore. So here are some predictors. The last slide showed common mental health disorders associated with suicide, but here are some predictors. Mental health disorder, substance abuse, prior suicide attempts. I'm going to go over the differences with someone who has prior suicide attempts and someone who never has had prior attempts. Lethal methods. Oftentimes you'll find that people have access to lethal ways. It seems that boys and girls, they have differences. Like girls typically go for poisons or pills, whereas males use like guns and things of that nature. Isolation or loss of support. So if you notice those changes happening with a child, loss of support system can be family members, parental figure, isolation. They don't hang out with their friends anymore. They want to be alone. Hopelessness. They feel like there's no way out. History of suicide. It can include prior attempts, but also it could be a family member who has died by suicide. modeling, trauma or stressful life events, anger, aggression, irritability, and physical illness. I recently came in contact with a child that has had a physical illness for several years. And I don't believe she typically wants to end her life, but she feels like because she can't do what the other children are doing, that she doesn't want to be around. So physical illness can also be an associated risk factor. Okay, so here we have chronic suicide risk and acute suicide risk. Chronic suicide risk refers to the ongoing likelihood of a person making future attempts and is based on historical information. There's an extent of background and current risk factors and presence of protective factors. People who have chronic suicidal risk can experience an acute suicidal crisis. So I'm going to talk about that now. Acute suicide risk refers to the level of current suicide risk with progression along a continuum based on escalating intent and risk. The level of risk also takes into account the extent of the individual's risk and protective factors. People who have acute suicidal risk can return to baseline behaviors for care. For chronic suicidality, for chronic at-risk suicidality is the baseline. So here's what that means. When you have someone that is of chronic suicide risk, the thoughts are their baseline. That's where they feel normal. And it may not be necessarily be an emergency, or they may not be in imminent danger where they need to be hospitalized, but there are times when they can be. And so that's why I noted that chronic suicidal risk can experience acute suicidal crisis. Now for the acute suicide crisis, they don't have the typical chronic ideations and thoughts. This is fairly new. Something came up that they haven't gone through before, and so it's more of an acute suicide risk. Engaging with an at-risk person. A trusting relationship with a mental health professional, teacher, guidance counselor, family, or other support system is one of the most important avenues to ensure the safety of the individual. So at that point, you would, if you come across the previous stated risk factors, that's something you want to do is engage with an at-risk person. And if they feel like they are in imminent danger, you don't want them to spend time alone. Interventions, stress, determine the level of subjective stress that the person is experiencing. You may come across students that are going through some stress, and it's important to know the level of that stress. Support. What is the quantity and quality of the support available? If the child doesn't have an adequate support system, that's important. Are family and friends nearby and able to stay with the person? It's good to find out all those things once you've assessed and estimated a high risk. Vulnerability. Is the person experiencing fear, panic, depression, and hopelessness? The most sensitive indicator is hopelessness. Suicidality. Determine if there is a plan to kill him or herself. Determine if there is a means to do that. Means meaning they have it planned out, they've already visualized it, they have access to weapons, they have access to pills. All those things determine if they have a means to do. Here's typically the treatment that goes after there is risk involved, and you know that you've had to refer or they've had to go to hospitalization. Treatment at the lower level is psychotherapy. A person can explore the issues that make them feel suicidal and learn skills to help them manage their emotions more effectively. When there's great danger, hospitalization allows the patient to be in a secure, supervised environment to prevent the suicidal ideation from turning into suicide attempts. And then if they don't present with great risk, they can even do outpatient treatment. And this gives them more control. It allows the person to remain in their place of residence and receive treatment when needed or on a scheduled basis. And depending on if they have a diagnosis, and that's another point that I wanted to bring up, suicidality is not a diagnosis in itself. If you can have persons that don't have a mental disorder and have suicidality. So the ones that do have a mental health disorder, a lot of times they have medication prescribed to them. Yes, someone who doesn't have a mental disorder, if they're hospitalized, they can get medication. But typically, if this person already has like depression or bipolar, a combination of prescribing the medication along with treatment goes a long way. Here's the danger with the medication though. Some medications lift energy levels before lifting the mood. So if that happens when the person is adamant about taking their lives, it puts them at greater risk. So we have to make sure that when they're referred, that the professionals will know if it's the best choice and what medications to prescribe for that person. After the aftermath of suicidal attempt, if you come in contact with a person who has made an attempt with suicide, the most important initial step is to ensure the person is not in any medical danger. This may seem obvious, but there has been reports by people who have made a recent attempt but appear to be relatively unharmed by it. Now, this is important because I mentioned earlier that you have boys that typically use weapons and girls, for the most part, would use poisons or medication. Now, if you come across someone who has made an attempt and this person took a poison or medications and they don't kick in till later, you won't know that they're in any medical danger. So if they've already said to you that they've made an attempt, it's important to find out what method did they use so that you know to get them help. Because a lot of the times, if they swallowed pills and you got to them, you just happened to cross their path soon after, it may not take effect at that time. So you won't necessarily know about medical danger. So it's really important to find that out. Follow-up care, and this is where the support system of school and family can come in. When any person is hospitalized, typically it's good for them, if they are released from hospitalization, they should be with a mental health professional as soon as possible. If that is not possible after an attempt, joining with the suicidal person. If they're coming to school every day, join with them, be a support system with them, have meetings with the family, get the family involved. When the family is a good support system, there's better outcome. Helping them find reasons to want to stay alive. So if they have these thoughts, ask them questions about their thoughts that they're having. Exploring motivations, improving quality of life, building resilience. All that stuff can happen within outpatient treatment or with a mental health professional, but I believe support systems can help with exploring motivations. It helps to asking the right questions can do that. Family involvement, you're going to find out the quantity and the quality of the support available. Are family and friends nearby and able to stay with the person? So all those are important after the event. And I want to show you a clip, a TEDx talk, and it's about preventing childhood suicide. And it focuses a lot on the previous side about the support system and family involvement, because it makes a great difference when there's adequate family support. So I'm going to see if I can play this.
I have to tell you that one of my patients, he's 10 years old.
And it must be on your other screen.
You can't see it?
We're seeing the PowerPoint right now.
Okay. Are you able to hear it?
Yeah, we can hear it. Maybe if you just put in a browser on this.
Because it's not showing on the second screen right now.
Oh.
He found out that I was going to be giving a talk. And so he came and
Can you see it now?
yes, he said, Jen, are you nervous? And I said, man, I'm super nervous, dude. So he just slides a piece of paper across my desk, right? And I open it, and all it says is whip and nay nay. And so I thought to myself, I'm like, dude, what's this about?
The new screen. So let's try that.
Say that again. You
So
were.
you need to unshare and then share again.
Okay.
Let's
Gotcha.
let's give and get and give and take and
There you go. Because
let's give it a shot. Ah,
there you go. Awesome.
my goodness, I love the person. But thank you so much.
thank you. Oops. Sorry. I think it went to another one.
Oh, so you just hit your back button to
Go back. Hit the back button. Hit the back button at the top.
There it is.
Right there.
Really fast.
There we go.
And if we just keep putting one foot in front of the other, even if it's on that clumsy, icy hill, we're eventually going to get close enough to that kid to either meet them or for them to meet us partway. So I made it up the hill, surprisingly, and I got close enough to Susie. I screamed out her name, and she came bolting towards me. And she gave me a hug, and I said, you know, Susie, what happened? What's going on? And she said, you're the first person to ask that. And that really stung, because that told me that we as adults are missing the opportunities to ask our kids the questions that they're wanting asked. So if we think about ways to build a relationship, there's really two paths, okay? There's this first path where you can enter the relationship with judgment. okay? And that is going to drive shame. Now, not only is shame highly correlated with suicide, but it also drives disconnection. And that's the last thing that we want when we're trying to build a relationship, right? So the other option, the other path is to enter the relationship with understanding and with empathy and honesty and trust. And that grows relationship, that grows healthy relationship. Now, each of these paths, they have an overarching question that aligns with them. So if we ask our kids, what's wrong with you? We're headed down the path of judgment. We're headed down the path of shame and disconnect. But if we take the time to ask our kids, hey, what happened to you? What's going on? We're investing in the time to build that relationship with that child. And so that day, had I asked Susie, what's wrong with you? You're so irresponsible. Why did you run away from school? First of all, I wouldn't have been asking the question in the first place, right? I've already pretty much made up my mind that what's wrong with you? Well, you're irresponsible, right? And I would have shut down the conversation right away. But instead, I was able to say, Susie, what happened today? What's going on? And Susie told me that it had been a really rough day. Susie lives with her grandpa. She doesn't have a mom, and her grandpa's health isn't doing so well. And so she was up all night crying and worried about her grandpa's health, okay? And so the next morning she woke up, she had mascara running down her cheeks from the night before, and her hair was a mess, but she woke up late. And so she didn't have time to fix any of that. She showed up to school and some girls started making fun of her. They started calling her some really nasty names. And she said, Jen, I was gonna fight back. I was gonna call them those nasty names back. But instead, I went to find my teacher to talk to her. But my teacher was busy. My teacher was in a class. And so I ran to find you guys to talk about it. Now, when we frame it that way, Susie doesn't sound so irresponsible. That actually sounds incredibly adaptive to me, right? That Susie was able to go seek the help that she needed in order to talk about what was going on in her life. But we have to ask what happened in order to get there. And so I think that that's where the hope lies. We know that the hope lies in building these relationships, but we have to revise the way that we're building them. Otherwise, these statistics are going to continue to climb. And so the hope really lies in revising the relationship to show up without a grudge and to ask the right questions. Because it would be phenomenal if there was a vaccine to prevent childhood suicide. I would be one of the first nurses to set up a clinic to want to get that going, but there's not. But my question to us is, what if that prevention has been within each and every one of us all along? Thanks.
I saw someone raising their hand.
Say that again, Ann?
Someone had their hand raised.
We've had a few questions that I've been trying to answer in the chat, but mostly people wanted to know, can I get this presentation? Will it be emailed? And yeah. I indicate that the presentation will be available on demand on the JD10 website. We'll share that link at the end. Did you have more presentation, or do you want me to ask this one other question that I saw?
Yeah, you can ask before we move on to the next.
Okay. Ms. Mackenzie asked, how do I detect someone if there are no signs of suicide?
Well, that's a very good question. 2 years ago, I was working with an agency, and the reason I started working with this agency, I don't know if many of you know about it, but 2 years ago, there was a school shooting at Marjorie Stoneman Douglas High School. And I live walking distance from the high school.
This is in Florida.
This is in South Florida. And when this happened, you know, all of the neighbors, the teenagers that are in my neighborhood, they all go to the school. So I see them. Some of them remembered me as I also did some teaching at the school. So when I heard about it, I immediately wanted to help. But then this agency was short of therapists for that area. So I said, well, it's right up my alley. Let me get in there. So I got in there. And one of the things that happened the last year was that there were students going through survivor's guilt. And so the ones that were going through survivor's guilt, last year there were two students, one young lady and one young man. And I believe the young man, he is a Jamaican also, but lives up by descent, like his parents are from Jamaica. I believe it's, or one of the other islands, one parent from one island and one Jamaican. But both of them, they both had no signs. The posts on the previous day were, I'm fine, I'm doing this, I'm doing that. The young man, he got up in the morning and asked his mom, do you want me to iron your uniform? Can I make you some tea, Mom? Have a good day, Mom. And it was that day. So Mom and Dad both explained that they didn't see any signs either. And then I discovered that my little cousin, she belongs to a church group, and this young man was in the church group with her. She had a little crush on him. So, and she was just 16 at the time. So she didn't see anything either. He was going to the church groups and all that, they were having fun, crack jokes. He was involved with the church. He had a good relationship with his parents. So what we have to do, because we are going to run across students like that, we have to establish rapport with the students. If you have a good relationship with them, they will come to you when things are going wrong. But let's say these students were acting their normal selves, but they typically didn't have anyone that they trust so much, which is one of the reasons why I missed one of the reasons why I missed doing interim teaching, because I would go to these high schools and I would cover for teachers that were on maternity leave, and these students would know my background, and immediately they would come in, they would bring their lunch during my planning period, they would come after school if I was still there, they would pull up a chair, can I talk to you? It's like immediately they want someone to talk to. So if you're a teacher or a guidance counselor or a dean, even an administrative assistant, it doesn't matter. They want someone that they can talk to and that they trust, and they will come to you, because I had no idea that students needed any help. And just as soon as they knew what I did, it was like fighting to talk with me. So you're not gonna always know. That's why I mentioned that there are suicidal persons that don't have a mental illness. And to be honest, there are people who have what is called, I think this needs to be a part 2 because there are so many layers to suicidality. There are people who have fantasies about it, but they have no mental health problems. It's just that certain thoughts cross their mind and they couldn't help those thoughts. And it's just a thought that passed through. And so, but then there are people that have the thought that passed through and they feel typically okay, but it keeps coming. It keeps coming. So you really can't know all of the signs, but the list that I gave you in the previous slides, that's what you want to look out for. And you'll notice things if you're close with a student. Teachers know all the strengths of their students all the time, and they know when something is off. The ones that really are connected and enjoy their profession as a teacher. I was just a temporary teacher and I loved it. I always welcomed them to speak to me. So, and if I did it long term, I got to know their personality. So I knew when something was wrong. I knew when someone was being bullied or not having such a good day. You know, if you're in a classroom for 3 months, you learn, you know, personalities and things. So it's not always certain that you would find it, but I would start by always just building a rapport, asking them how was their day, how was their summer break, so that they know that you're that person they can talk to. Did that answer the question?
I think so. Ms. Faye Robinson asked, what are the signs and symptoms? And I think you had a previous slide that had addressed those signs and symptoms. But as you're saying here, even though there are signs and symptoms, there may be the anomaly, might be somebody who wouldn't display the typical signs and symptoms, and those are also troubling. So,
yeah.
Right. Ms. Edwards asked, she said that she has a boy whose mother committed suicide, and the father did not want him to do therapy because they don't want nobody in them business. And Ms. Gordon also, she had something similar because she said, what do you do if somebody doesn't want to do talk psychotherapy as an intervention?
If someone doesn't want to do talk therapy, there are other therapeutic ways they can go about it. I think having that support system, it could be a friend, a group of friends, a place where they go, if it's a church that they go to, having those support systems can be in place because they will keep an eye on you. They will look out for you. They will be an ear for you in case you don't want to. And you know, you have friends that always give their advice, but there are some friends that really are good about just listening. Because we can't really force them to go. We can psychoeducate about it and let them explore it on their own.
Mm-hmm.
But the most important thing is that they have a quality support system.
Okay, great. Someone says, from what I've learned over, Ms. Trudy Ann Fife said, from what I've learned over the years, where's my screen? From what I've learned over the years, once a person has decided to commit suicide, he or she might actually feel relieved about that result. So he or she may become somewhat relaxed and maybe even seem happier. And then that's why when they show signs that would indicate a desire, that's when they would show no signs to indicate a desire to harm themselves. So because they've made that decision.
Because they've already made the decision that they're going to do it, or they've attempted.
Right. That's what she's saying. Once they just feel relieved that they've, you know, they've resolved that situation. So that's why they feel happier, and then may not show signs to other people around, because now they're just happy with the choice that they've made.
That person could fall along the lines as the chronic risk, suicide risk. I had a slide on the chronic and acute. Remember I mentioned that having the thoughts and the plan is their baseline behavior.
Right.
So that's probably what it is. If you look against their histories, any mental health issues, you would find that when they think about it, that's when they are stable. So that's probably what you're talking about, the chronic risk.
Right. Okay. Okay. So Mr. Joseph Green says, since we don't readily detect signs, shouldn't there be ongoing screening for suicidality?
Yes, you can definitely, there's a slide I have, and this is why I'm glad that this will be emailed to you. There's a slide I had on assessing and estimating risks. So you're going to check stress levels and all those things to see, you know, how high. You could even rate them on a scale of 1 to 10 to see how high their risk levels are. And if you determine that it's, you know, that this person needs some help, you can refer them to a professional. If you're dealing with, someone mentioned that they have a parent that said they didn't want anybody in their business.
Mm-hmm.
Well, the child goes to school every day, right?
Right.
I would definitely arrange for a support system at the school if the father is refusing help. I'm not sure how this CPFSA plays into this, because would that also count as medical neglect?
Mm.
I mean, if the child had, like, over and over again attempted and no professional help was sought, then would the father get in trouble in Jamaica for not getting help for this young boy?
Well, that's a question for a legal team, or probably even the educators, the higher up in the education system.
Because it's the same as if they're sick or they broke their arm and you wouldn't take them to the doctor. And that's the other thing. We have to see it, just like the video I showed. Well, I think it cut off the beginning, but at the beginning of the TED Talk video, there was some talk about treating it the same way you would treat a physical illness.
Oh, yeah, okay. Yeah.
So it's important, but in the meantime, before you know, sometimes all it takes is psychoeducation. He may not know about the level of confidentiality that's involved when a child is seeking help from a mental health professional.
Mm-hmm.
You know, these are the things that need the workshops that need to be in schools. And I always said that high schools need mental health 101 as a class, because you have young people that feel that way too. They don't believe in speaking to a mental health professional. But if they're educated on what it really is about, you know, they may want to try it out and won't be so reluctant to seek help when necessary.
Right. Okay. Didn't she say it was the parent who committed suicide? I'm not sure what Mr. Henry is asking there.
Oh, the parent?
It was a
Oh,
mother.
like the mother
Suicide,
died
and the
by suicide?
yeah, and the father was saying that he did not want the
He
child.
did not want anyone to. Okay. So, you know, the child can choose, he's going to choose someone to talk to.
Okay.
Unless he's been taught to hold things in. If dad is the type of person that that raised him in a way where he wasn't able to express his feelings, then that's a whole different story, because then it's going to be difficult for him to open up. But if he's already willing to open up, then how can he control? He won't be able to control if he chooses to speak to someone at school. I mean, you wouldn't be providing psychotherapy, but you would be someone, an ear for him to listen to.
Mm-hmm. Okay.
And then depending on the age of the child, I mean, can you really control it if the child is a teenager? Now, if it's a young child, I say that maybe meeting with the dad and talking to him alone and educating him on how it can help.
Mm-hmm. Okay.
You know, explain why you understand why he's reluctant to seek mental health advice from anyone. Because a lot of people have that issue with the confidentiality. So
Mm-hmm.
if they're educated on it, some of them turn around, they change their minds and they give it a shot.
And they see that some positive effects, and that kind of helps. Yeah.
Right.
I have a question from Sim Green. If a student's parent has committed suicide, is it likely for the child that the child would follow the same pattern?
It's possible. They are at higher risk. When there's a history, they're at higher risk.
Mm-hmm.
And especially, I mean, I've dealt with families that I know of how a person died in their family, and the parents deliberately kept that away from the child because they don't want them to have any ideas.
Mm.
But they seem to be at higher risk when there's a history in the family.
And Ms. Shawnette Grant says that in general, mental health is a discussion that we seem to shy away from, and so sensitization is needed in early years.
Sensitization is needed in early years?
Mm-hmm.
You know, there are other third world countries that I read about where suicide among children was a trend. And if I can locate that book, I will refer it, but it was a trend, and it wasn't any extreme circumstances like we're talking about here, like mental health issues or life stressors. It was simple things like mom grounded the boy and told him he couldn't go to his school dance, and he hung himself because he wasn't able to go to the dance. Now, I believe this took place in a Central American country, but this was talking about how it has become a trend. So I'm not sure at what age would be the most beneficial to talk about it. I believe that it should be more about emotional regulation at the young age, because when you are unable to deal with life stressors, and anyone can chime in, and even you, Dr. Grethel, if you want to say something about that, but sometimes they're unable to regulate their emotions, and they don't want to end their life. They want to end the pain that they're feeling. So if a young child is taught early on, and there's so much material out there, even Sesame Street has it, there's so much material out there about emotional regulation. Mm-hmm. And when that child grows up learning how to express and how to soothe themselves and things like that, then and problem solving skills also, they will grow up learning how to deal with life stresses as well.
Absolutely. I think that's absolutely right. And I think what the person may have been suggesting too, though, is that we as adults and caregivers, or that we become sensitive to those symptoms, and that we're able to kind of help pull people out. Marcia Nebhart, she said, show them love, try to win their confidence. She said she teaches young children, and because of the rapport, they share everything.
Absolutely. I say this to parents all the time. You know, I have parents that, and many of you can attest to this, that want their child to do this or want their child. I said, did you know that if you had a great relationship with that child, you wouldn't even have to pressure them? Just because they have that relationship with you, they will consider your views and your ideas.
Mm-hmm.
They won't be so ready to resist and everything. Is because if the relationship is not there, they're going to rebel. They're not even going to consider what you're talking about. But that quality relationship is very, very important.
Absolutely.
And I think you had said something, Anne, about talking to them at a young age. I don't think that necessarily children need to be exposed to it, you know, as a preventative measure.
That's why.
But I think that, you know, if they've heard of it, if they know of someone who's done it, or, you know, they see it on TV, then, you know, it's up to us to talk to them in age appropriate ways,
Right.
you know, about it. And so that they can understand it and not be scared of it.
Right. Absolutely. Because I don't feel comfortable discussing with like 5 and
4-year-olds.
Yeah, I don't. But emotional regulation, yes.
Definitely.
Absolutely. Somebody asked, do you offer your services to parents also?
Oh, yeah, absolutely.
Okay. And Ms. McKay Kenlow said sometimes it can be a case of extreme anger and feelings of disappointment in the moment that leads somebody to make a spur of the moment misjudgment in their action, which is to commit suicide. So I guess it's building tools also, giving the children, if it's kids we're working with, giving them tools for how to handle disappointment and anger and the bullying and all that.
Right. Mm-hmm. Absolutely. Someone mentioned something about cutting, and which is really, really good. I'm glad they brought it up, the cutting. So cutting seems to be going around. It seems to be a trend also with young people, but most of the young girls I come across are not suicidal. The problem is that you have some that engage in self-harm and cutting behaviors, and you will find out that one have died from cutting, but they actually accidentally cut too deep. Mm-hmm. And so you have some cutters that are actually trying to make an attempt, and then you have some cutters that they don't want to make an attempt. They are just making superficial wounds because they're angry with themselves. They're trying to release some pain, and then when they see the blood, they stop. And that's really important, because there have been times when I see girls with, you know, and I observe the body, because I'm one of those types that your skirt is too short. I'm just that type. So if I have that relationship with them, I can tell them, what is your skirt doing up so high? But when I observe body language and how they're dressed and everything, I've come across cuts. And when they know I'm paying attention, they try to hide it somewhere else. Now, I won't be allowed to tell them to take off your pants, let me see your backside and see, you know, because they get creative. They hide it in different places too. So what we typically do as mental health professionals is we educate on the self-harm. There's protocols and manuals on how to deal with that. And it's a relief. It's always a relief to me to know that that some of them or most of them don't want to die. They're making superficial wounds. So we walk through that process, and I follow like a strict protocol for cutting. There's material out there. There's workbooks out there for it. If you want to just know how to look out for it, but they do get creative once you notice. So they'll hide it. And, you know, if you're in a school, we can't take their clothes off and look. So, but hopefully when you do have that relationship, they talk to you and they say, I cut myself yesterday. They will tell you if they trust you and things.
We're coming up on time. I know we got started a little bit later, and there's some people who have another call. So I see two other things here. Some children are loved, but they're vulnerable to peer pressure, says Ms. Orlean Denny, and to negative input from persons that they looked up to. And then Nikisha Bernard said, what about withdrawing some from themselves? Some would believe, and some people think, that this is a normal teenage thing. So how do you suggest dealing with those children who have the peer pressure, for one thing, you know, from other people looking up to them, and then also maybe somebody who might be withdrawing?
Repeat that last part of your question again.
That's a child might be withdrawing, like they're pulling away. What do you suggest? How do you handle the child that's withdrawing and not, you know, maybe the teacher or the parent is, because what happens is that it's normal teenage, something that, you know, so them teenagers say they don't want to listen, and you know they think that that's just a teenager thing. So how do you suggest?
The parents is withdrawing or the child?
The child is withdrawing, and the parent is kind of minimizing it and saying it's a teenage behavior. This is just normal for how kids this age, they just like staying in their room, they don't want clean up, they don't want bed, they, you know, those kinds of behaviors, which we know those behaviors are signs and symptoms when you're not taking pride in your body again, when you're, you know, not socializing, you're not enjoying things. Those are signs of sadness and depression, and not necessarily of teenagerhood. So how do you, maybe as a guidance counselor, what could the guidance counselor do either with the parent or with that child that's withdrawing?
Okay, well, I've known some guidance counselors too, and this is something I did at one of the schools I worked for, and in another state. I actually worked at a school where Black girls were the minority, and they were faced with so many issues because it was a high profile private school. And so I got together with a guidance counselor and a dean, and the three of us got together and created a group, a lunch group. And we had those children come join the lunch group. What ended up happening is that parents would come to events to learn about a certain thing. So this goes back to the psychoeducational piece for the parent. Guidance counselors can always hold events at the school for girls to attend, for just parents to attend, for parents to attend with their girls. When you, especially if you make it like a mother-daughter type event, a father-son event, or just for the parents alone, or just for the children alone, that way they can get more information about development, things that go on with adolescents. You know, instead of thinking it's a normal teenage thing, they can get more educated on it.
Mm-hmm. And here, I didn't realize, I think we may have cut you off. Did you have more of the presentation to go, or
yes, I did, and it's just a few more slides. I can speed through it.
I just have one quick thing, because somebody mentioned a very substantive topic. She said that an 11-year-old tried to commit suicide last week because they felt bored because they're at home. Do you have any thoughts or anything that you might, any wisdom you can lend to address an 11-year-old who is making a suicide attempt due to boredom?
So this child hasn't been able to go out, of course, because they're quarantining or something still, or just
likely.
Okay. I've had a few of those, and what I came across was an enormous amount of resources that they can do online. But here's the problem: if they don't have access to internet, then that's another issue altogether. You know, I also have a workbook educating on the pandemic to children, so that they can understand it's not being stuck in the house, but it's for safety and for protection. And so reframing those thoughts they're having about being at home could help a lot, because sometimes it's just thinking of it differently can do the help. I even have like activity, like a time capsule activity for COVID. And so the children, it's a workbook. They get to decorate it, put everything in it about themselves, and then they can bury it somewhere in the yard. And they don't dig it up until maybe they start secondary school. And then when they dig it up, and they'll say, oh, I remember when we were stuck in the house and we couldn't go nowhere. And, you know, so it's those type of activities. And I believe I'm able to educate on it from age 4 or 5. So it's for young children too, so they can understand about it. And you'll be surprised that the young ones, they're interested in it, because it's like a cartoon that they can watch and learn about cleaning, washing your hands. And it takes a lot of reframing, especially if it was an active child that went out with friends and did everything with their social life, means everything at those ages. So
What's that workbook? Is that your personal workbook, or is that something you can share?
it's something I can share.
Hilton, yeah, Miss Hilton is asking. That sounds like it would be a good resource. And then if you could just get to the rest of the presentation. I'm sorry that we took a detour, but we can share the screen again and finish that part as well. And maybe you can put the workbook information in the slide too.
Okay. Okay, so here I'm going over the role of the school faculty and administration. You're going to have awareness of need for intervention. So the awareness is what I posted in the previous slides about risk factors and mental health issues. You're going to have awareness of that, so you know what to look for. Be able to identify and refer to appropriate care. If you know your students and you can identify that something is off, refer them to appropriate level of care. And this is important too, because if you're coming across someone, like someone mentioned about the young lady who she was happier and relieved because she was planning an attempt at suicide. Hospitalization may do some damage if she's at the chronic level versus an acute person, but it takes really assessing and estimating the risk, the stress level, so that you can determine, does she just need family support, or does this person need to be hospitalized? Support vulnerable students. So if you know those students don't have the best parents, family support, they're at risk for other issues because a family member died by suicide or anything that could make them vulnerable, they have many of the things that are on the chronic or acute risk. Support those vulnerable students. If you build it, they will come. So if you create meetings and groups and things at the school, they will come if they need to. Your role is not to provide psychotherapy. This should be left to a professional. The school team needs to work together, debrief often, and reach out if necessary. Sometimes we tell people to if you need anything, just let me know. Sometimes they don't want to be a burden. A lot of children and people in general who have contemplated suicide, sometimes they feel like a burden. So it's up to us to reach out, and when we ask how you're doing, really mean it and want to know, be genuine with reaching out to them. So that would be the role of the school faculty and administration. This is after the fact, postvention. Postvention is an intervention conducted after a suicide, largely taking the form of support for the bereaved, family and friends, professionals, and peers. A lot of times this happens when there's a student at the school who died by suicide. Family and friends of the suicide victim may be at increased risk of suicide themselves. Someone asked about being risked if someone else in the family, and see, I have it here. Family and friends of the suicide victim may be at increased risk. Postvention strategies. Create a school safety plan with the student and support staff. Follow up with the students support group. Regular in-school monitoring by support staff. Share observations with relevant school staff members and admin. Provide academic accommodations as needed. So if this student was out of school for a certain period of time due to an attempt and are recovering, academic accommodations, you don't want to say, and I know no one will say this, but this is just to put it out there that, oh, you missed your exam. You're not able to take your exam. Make accommodations for that student. Provide an atmosphere of caring, acceptance, and support. I should have also put the judgment in there, which is the video spoke about being non-judgmental also. When they know that you're accepting and caring and supportive and it's genuine, they will come to you also. Here are some myths about suicidality, and this is important because a lot of people have their own ideas about it. It's dangerous to ask a depressed person whether they're considering suicide. People who die by suicide are selfish. People who want to die always find a way. Most suicides happen suddenly and without warning. Someone who has their act together isn't at risk of suicide. Most suicides happen around the winter holiday season. When someone recovers after hitting rock bottom, their risk of suicide declines. Suicide only affects individuals with a mental health disorder. Suicidal persons don't have to have a mental health diagnosis. Suicide by itself is not a mental disorder. So these are myths. The last one is a note about all of these myths. Suicidal persons don't, it's true, they don't have to have a mental health diagnosis. Suicide by itself is not a mental disorder. So this is true. The rest, everything on top is all myths. This, I don't think we have time to go through each one, but quickly, people who die by suicide are selfish? No. I'll skip to this one. Most suicides happen suddenly and without warning. Studies have shown that majority of them actually do show signs. So you have some people who may not show signs, but the majority of them do show signs. Someone who has their act together isn't at risk for suicide. There's a such thing as concealed depression, and they could very well be at risk. Concealed depression is smiling in the face of adversity, laughing with friends, you won't know what's going on. So just like those two students I mentioned to you, they had their act together because one was going to a church group with my little cousin and had a good relationship with his parents, but he ended up having access to a gun and using it. When someone recovers after hitting rock bottom, their risk of suicide declines. No, this type of person is going to need care and treatment for several weeks or months down the road. So they need the support. So suicide only affects individuals with a mental health disorder. So we all know that you don't have to have a diagnosis to be suicidal. Here are some facts about suicide. Suicide is preventable. With the right tools and interventions, it can be preventable. Most suicidal individuals give definite warnings of their suicidal intentions. Talk about suicide does not cause someone to be suicidal. Suicide occurs across all age, economic, social, racial, and ethnic boundaries. Suicide behavior is complex and not a response to one problem that a person is experiencing. Surviving family members not only suffer the trauma of losing a loved one to suicide, they themselves may be at higher risk for suicide and emotional problems. Now I'm going to give you a stat that's currently in the US, and then I'll tell you about one that you can, a resource you can go to for stats in Jamaica and the rest of the world. In the US alone, suicide is currently the 10th leading cause of death, approximately 14 per 100,000 persons. Now, if you go to the WHO organization, the World Health Organization, you'll be able to find the stats for Jamaica and everywhere else in the world. Here are 10 things not to say to a person contemplating suicide. How could you think of suicide? Your life's not that bad. Don't you know I would be devastated if you killed yourself? How could you think of hurting me like that? Suicide is selfish. Suicide is cowardly. You don't mean that. You don't really want to die. You have so much to live for. Things could be worse. Other people have problems worse than you and they don't want to die. Suicide is a permanent solution to a temporary problem. You will go to hell if you die by suicide. Now, I quickly want to bring number 9 to your attention. Suicide is a permanent solution to a temporary problem. We have to change the language and refrain from saying that. For a while, years ago, people used to use this as a model for suicide. But if you look at the language, you're saying that it's a solution. We don't even want that word in there, that it's a solution. So we have to change the language. And the last slide, and then we'll be done. Responsible communication tips. These are some things that you can say instead of the previous slide with the things not to say. I'm glad you came to talk to me. I know this is hard for you. It sounds like you're really overwhelmed, but I'm so glad you shared. I'm so proud of you because I know it took a lot of courage to come forward to share this information. I'm concerned for your safety. Part of ensuring your safety means I need to share this information with administration and guidance. You are not in trouble. They will know how to get the help you need. And also, if you have that relationship with them, it's okay to let them know how, remind them of something that they did that you liked, or remind them of things that they did to contribute to the school as a whole, and point out those things so that they remember all those good things about them. And that's it. Here's a couple of resources. This is a book. I'm going to stop sharing, and I want to bring attention this book. This is The Unapologetic Guide to Black Mental Health. And in this book, it talks about a different approach, because the approaches that we use are not blanket. So this young lady, she's a doctor, professor of psychology. She wrote about different approaches, especially for young Black people. This book is available on Amazon if you want to read more on family support systems and risk, and how spirituality is connected. And she has done research and found that when someone is more in tune with their spiritual connection, they were less at risk for suicide. Thank you. Can you show, oh, can I show the book again? The Unapologetic Guide to Black Mental Health.
Okay, I'm thinking that Carlene got kicked off again.
Oh.
She's trying to text me to let me know. I think there was a question that one person had that it was about slide, the second to last slide that you showed. It was, I think, point number 8. I'm not quite sure. For point number 8, she asked you to go back to that.
Okay, point number 8.
And to explain it.
Number 8.
I think it's the second to last where you listed the 10 things.
Let's see. Remember? Oh, other people have problems worse than you and they don't want to die.
Mm-hmm.
What was the question about number 8?
I'm not quite sure. She said if you could go back to that one.
Okay.
Yes.
So the number 8 was other people have, it's on the slide, the 10 things not to say to a person contemplating suicide. Other people have problems worse than you and they don't want to die.
Okay. Can you explain that as to, just sort of explain that as to why, you know, that could be detrimental?
Well, the thing is, this is something that is very common for people to say. The intention is good, because they're trying to point out that you don't have it so bad as most. But the thing of the matter is that problems, trauma, all kind of stressors are subjective. So we can't know who's worse off than the other person. And it's minimizing and dismissive. So it's not the right thing, that you actually have them feeling worse. So it's not a good thing to say. Thank you all for signing up.
Right. I think there is one more question, just one. I think the person says, Andrea Brown says, I have a boy who no longer takes pride in his general appearance. He doesn't want to wash his clothes. He is unkempt and participated in alcohol and substance abuse. He started acting out since his grandmother and close confidant died in 2016. How do I reach him? Also, he resents authority.
It seems like he's showing more anger about what he's going through. He's showing more anger. I would definitely get him professional help. He hasn't been able, he's probably still dealing with the grief. There was a time when they did put a time limit on grief, but there is no time limit on grief. So I would definitely seek professional help so that he can talk about why he's feeling. He seems like he's presenting with his secondary emotion, which is anger. So we all know that there's underlying emotions when a person shows with anger. There's something else going on.
Okay. Okay, I'm trying to get Carlene back on. She's gone for good now. Oh my dear, oh goodness, she's gone for good. Okay, so I want to say thank you, Mrs. Moodie, for, and it was really informative. And I believe that for those people who are asking for the PowerPoint, to my understanding, it is there on the link for JD Tan that you can actually request it and it will be given to you. Simone, could you confirm that for me, please?
Yes, I'll just need the copy from Carlene. I don't have it. So once it's me, I can upload it.
Okay, then. So you will upload it in the chat?
No, I need the actual file. Then I'll upload it to the websites and we'll send it out with the certificates.
Okay, wonderful, wonderful. So, Anne, thank you so much for your presentation.
You're welcome.
And thanks to everyone who was here today. Thank you, and look forward to seeing you soon. Goodbye.
Goodbye.
Goodbye. Goodbye.
Bye.
I see Yasmin is trying to share her screen. I'm not quite sure why that is.
Maybe accidentally.
Okay. All right then. Okay, everyone. Goodbye. Thanks.